Okay, everybody, I think we can get started now. Again, this is Neil Andrews from IASP. I would like to welcome you to today's webinar on interprofessional pain education, moving the agenda forward. Today's webinar is actually the third webinar in a series of webinars that we have created for the 2018 Global Year for Excellence in Pain Education. I want to welcome everyone, and I'd also like to welcome those who are following the webinar on our Facebook live stream. Before I introduce our moderator, I just wanted to bring your attention to some information that you'll see on the slides that appear now. There are several ways to participate in the webinar today. After the talks, we'll have a Q&A session, and you can type in your questions into the Q&A area of your Zoom meeting control panel window. You can submit questions at any time that you like. As I mentioned, we're live streaming the event on Facebook, and you can share our Facebook Live video on the IASP Facebook page with friends and colleagues. And you can also do some tweeting. You can tweet us at #GYPainEducation and also #IASPwebinar. And you can follow at IASPPain on Twitter for live updates. Next slide, please. Also, would just like to draw your attention to, we have some upcoming webinars for the Global Year for Excellence in Pain Education. We have one on October 25th, looking at education innovations to improve provider knowledge to care for older persons with pain. And we're actually going to open up registration for that next week. And you'll see also that in November, mid-November, we have another webinar on pain education in developing countries. Okay, so let's get back to the webinar. I now have the pleasure of introducing our moderator, Deb Gordon. Dr. Gordon is the co-director for the Harborview Integrated Pain Care Program and teaching associate with the Department of Anesthesiology and Pain Medicine at the University of Washington in Seattle. She's also a co-investigator for UW's NIH-designated Center of Excellence in Pain Education. Dr. Gordon is also active in a number of professional pain management societies and has served as a board member for the American Pain Society and is also a fellow in the American Academy of Nursing. She also chairs IASP's Education Initiatives Work Group and is on the executive of the task force for the IASP 2018 Global Year for Excellence in Pain Education. Welcome, Deb. Please go ahead.
Thanks, Neil, and thanks to everybody who's participating today. It's my pleasure to introduce my fellow faculty and my good friends. First, I'd like to introduce Scott Fishman. Scott is the Fullerton Endowed Chair in Pain Medicine, Professor of Anesthesiology and Psychiatry, and the Chief of the Division of Pain Medicine and Executive Vice Chair for the Department of Anesthesiology at the University of California, Davis. He is also the Director for the Center for Advancing Pain Relief at UC Davis. Dr. Fishman is a past President of the American Academy of Pain Medicine, past Chairman of the Board of Directors of the American Pain Foundation, and previously served on the Board of Directors for the American Pain Society. He is the past chair and current member of the Pain Care Coalition, and he advocates for safe and effective use of pain treatments with physicians, consumers, and lawmakers. Scott has led a national and international effort to transform pain education through developing and enacting core competencies in pain education. Judy Watt-Watson is a professor emeritus at the University of Toronto Bloomberg Faculty of Nursing and senior fellow of Massey College, and an associate scientific staff in the Department of Medicine at Mount Sinai Hospital. Her research has focused on pain prevalence and related risk factors, particularly for cardiac surgical patients, and education interventions for health professionals and patients. She is past president of the Canadian Pain Society and chaired the IASP subgroup developing the Interprofessional Pain Curriculum. Judy's an executive member of the University of Toronto Center for the Study of Pain and was the inaugural chair for the Interfaculty Pain Curriculum. She is also an executive of the task force for the IASP Global Year on Excellence in Pain Education. So our objectives today are really to outline the foundational core competencies for pain and for interprofessional collaborative teams. We're going to work on describing the framework and core principles for interprofessional education, and hopefully have plenty of time for discussion and examples of how we move this forward. So each of us will have 15 to 20 minutes, and this is kind of how we're going to break up. Scott's going to start with talking about the background and the gap and crisis that led to some of the competency and agenda in the US. I'll talk a little about interprofessional education and Judy will also talk about the status of pain and programs and evaluations. We should have a good 15 minutes at the end for questions and answers, so please, again, type your questions into that question and answer box, and then I'll moderate those at the end. So I'm going to hand it back over to Scott to begin.
Good morning, everyone, and or good afternoon wherever you are. It's morning where I am. I'm thrilled to be able to be here with you today to give this presentation around the issue of pain education, really the education gap that we suffer from in North America, and I would suggest worldwide, and how we might look at it a little differently through the eye of having goals for education and embracing those goals when we look at our schools for health professionals. I have these disclosures up. Some of them were mentioned. I have no conflicts in giving this talk to you today. I think anyone in the U.S. would recognize that it's a difficult time in pain management, largely because we're faced with contradictory problems. The discrepancy that we face is based on the fact that we have a substantial population with chronic pain, let alone acute pain, pain in children, pain at the end of life. But just chronic pain is estimated to be 50 to 100 million Americans at the cost of about $600 billion a year. At the same time, we use most of the world's strong painkillers in the form of opioids. These don't really go together, and I would hypothesize that one of the root causes of this discrepancy is that we recognize that pain is a serious problem. It's the most common reason a patient often goes to see a clinician, and yet we don't educate our clinicians adequately to manage that problem. So in the United States, we have substantial literature on the fact that we have inadequate curricula and educational programs for our medical students, as well as for other students. Our national pain strategy, which is a strategy that was advanced by our federal government, the Department of Health and Human Services, and really a product of the Secretary of Health and Human Services, essentially states that education is an essential part of the necessary cultural transformation of the approach to pain. And although pain is one of the most common reasons for healthcare visits, most health professions' education programs have yet to give it adequate attention. I've just given you some examples of some of the work that's been done around our country on pain education that shows that it's inadequate. There's a quote here that chronic pain is a complex patient experience. Chronic pain as a complex patient experience is not adequately taught in U.S., Canadian, or British medical schools. One of the seminal articles is by our dear friend and leader in this field, Judy Watt-Watson, who will speak in a few minutes. She did an article, and she led a study in 2009 and produced an article that showed that none of the professions were well prepared, but the best prepared were the veterinarians, and it led to a famous cover that you've probably already seen before, that your dog can get better health care than you. So really the question I'd like us all to ask is, why do we have an education gap? We spent years and years and years raising awareness around pain. In the United States, we even made pain the fifth vital sign. I think with the very genuine positive expectation that if pain were only recognized, it would be treated. So how is it that we have this gap? And one is that we don't care. I think the fact that we made pain a fifth vital sign suggests we do care, and I think most of you on this call probably recognize that there are a lot of efforts that have been underway for decades that demonstrate that we do care, not just the pain community, but well beyond. So I don't know that caring is the issue. Maybe we're not trying hard enough. And if you just look at the work product from the IASP and others around developing curriculum, you can see that people have been working very hard in this area for many, many years. So I don't think the problem is working hard enough. And then it leads us to the question of, are we taking the right approach? And that approach has been to continue to generate curricular outlines and curricular content and hope that we can get these into education programs. I think that evidence suggests that that's a failed process, a failed approach. And we need to look at different approaches, which has actually led to this idea that we need to have an anchoring point so that we don't get ignored in curriculum committees or by health professions who really have the same goals that we have, to graduate competent clinicians. And we believe that you can't graduate a competent clinician who isn't competent in understanding pain, recognizing pain, understanding safe and effective treatments, and understanding context. So this is an article that my colleague Heather Young and I wrote about this subject and where we think we've gone wrong with putting really step 2 and 3 before step 1. Step 1 being setting the goals, deciding what is the goal of education, and then working towards the outlines and the content. The reason that this is important is because in my experience and the experience of many of us who have tried to do this work, if you've seen one curriculum, you've seen one curriculum, meaning that we really don't agree on exactly how to educate toward the goals that I think we all do agree that we want to reach. That is a competent clinician. That is a clinician who can understand effectively and safely treat pain. So with that, we've reformulated what might be a strategic process, which is to set those goals and then expect our educational programs to meet those goals. Now, I want to be really clear that what I'm talking about today is competencies, but not competency-based education. Competency-based education is a foundational principle around how education might be best pursued over all aspects of education, using goals at each step. It's a controversial model, and it's really not what I'm putting forward today. What I'm simply advocating for is that we have competencies which serve as the goals so that we know where we're going before we start, and we know where we're going while we're going there, and we can confirm that we got there when we're done educating clinicians. And that's really what the core competencies were all about when we formed a panel of experts, largely from North America, to look at what are the things we agree on in terms of the goals of education for clinicians in any health profession. So I want to emphasize that what we looked at was not the high points, but it was actually the floor. It was the bare minimum expectations of any health professional from any school. So we had folks from as many different professions and kind of walks of life in healthcare that we could find. We didn't have them all, but we had quite an array. And I'm going to flip through these quickly, just not to dwell on them, but I want you to see that we had nurses and physicians and pharmacists and acupuncturists and psychologists and veterinarians. We had nurses and who were nurse leaders and individuals who were specialists in health, in education science. And what happened over 3 days was that we were able to kind of go into that dark hole of argument about really what is it that we're trying to do. And we came out with remarkable agreement at the end when we were able to get away from the curriculum and just really focus on the goals. And what it came down to were 4 very clear domains. And we put those domains into language that that synced up very well with the IASP curriculum that was out there. But we also just made very plain language around the 4 elements that are essentially the domain or the major competency umbrellas that we're looking at. And they're very simple, and I've already said them. They are: domain 1 is what is pain, domain 2 is how is pain recognized, how is it assessed, domain 3 is how is pain safely and effectively treated, and domain 4 is how is pain affected by context. That is the difference between acute pain, chronic pain, cancer pain, terminal illness, etc. I'm not going to go into detail about the competencies any further, but I'd be happy to answer any questions that you have afterwards. I just want to say the competencies have been reviewed and endorsed by most of our major interprofessional, multidisciplinary professional groups in the US and internationally, including the IASP. I also want to say that they're not the only set of competencies out there, and I want to address. I want to recognize the competencies that came out of the state of Massachusetts around addiction that also sync up very well with our domains and our competencies. And I raise awareness to this because there was a recent survey of our medical school deans by the American Association of Medical Colleges, an important survey, but one that I would tell you in advance that I would be fairly critical of. And this was a survey that was done in 2017 to assess current or anticipated plans in addressing the opioid epidemic. And they contacted medical school deans or their designees at all of our accredited U.S. medical schools. And they used 2 basic sets of competencies. It was the Massachusetts competencies for addiction that or substance abuse that I showed you, and the Interprofessional Consensus Summit, which is really a misnomer. The competencies that we made were based on an interprofessional consensus summit, but the competencies apply to all of the professions individually or interprofessionally. So they used the core competencies that we came up with and the Massachusetts ones that I think are probably the 2 competencies that are best embraced in our country right now. And they asked, if you're addressing these, and 87% of the respondents reported that all 4 of the domains are addressed in their schools, really without any evidence of that. And 100% reported that at least 2 out of the 4 domains are covered in their institutions. Again, without much evidence of that. The vast majority reported that the individual pain competencies, if you really drill down on them in the 4 domains, are taught within the required curriculum along the 4 years. So a very positive result that went on to let them say that pain is covered, addiction is covered, and really all is well. I'd like to tell you that I don't think that that's true, and there's a literature behind this where nobody else has found that to be true, and I think it's in the interest of the deans to see that pain is in their curricula, but often the pain that's in the curricula isn't really teaching pain, but it's pain as a descriptor. And this is something that we found when we were invited by the National Board of Medical Examiners to review the USMLE, the United States Medical Licensing Examination, for content related to pain competencies. It was an extraordinary opportunity to use the competencies to look at the one test that every physician must pass to get a state license to practice medicine. So we assembled a blue ribbon panel of 12 internationally recognized experts, and we went to Philadelphia, the home of the National Board of Medical Examiners, and actually under a secure observation 2 days, pretty much watched the entire time. We reviewed test after test in groups of 2. So we had 6 groups in groups of 2. And this will give you just a sense of who the participants were. And again, these are leaders in the field of pain medicine and pain education. We constructed a novel rubric to look at these questions as objectively as we could, because frankly, this had never been done before. I don't think the slide that's up there now is readable for you. So I'm going to zoom in a little bit to the left and then show you the right. So basically, we created a rubric where we looked at a question and asked, does it include pain? And if the answer was no, we went no further. If the answer was yes, then we answered all the other questions, which is how closely is the question related to pain, fully, partially, or not related? The second is the quality of the question. Did it make sense? And then we looked at the question in terms of what domain it would fall under in terms of the competencies and the number, the competency number. And there were, I think, 5 to 7 individual competencies under each domain. And then we looked at major topics in pain. We took major topics from published literature, and then we came up with other topics that we didn't think were included in the literature, just from ad hoc from the group. And then we looked at key public health issues, and I'll show you what these are. And we looked at the testing strategy as well. So these are the major topics, and these are on the left of the right-hand box, and the key public health issues are on the right. Again, we strive to cover all of the major areas of interest and issue in pain care that any of our leaders felt were relevant. This is a rubric that just shows you how we flowed. So we basically saw, we had 3,728 questions available to us. In the 2 days of reviewing the tests under observation, we were able to get through 1,506 questions. Of those 1,506 questions, 1,074 did not include pain. 432, about 29%, included pain as part of the question. But what was found is that about 13%, or 200 of those questions, really almost half of the questions that included pain was using the term pain as a descriptor only. So the question wasn't actually testing on any pain content or pain issue. And this is important because when we look at curricula, we see pain, but we don't actually see it taught. It's a descriptor for teaching other things. But it was quite remarkable to see that about 15% of this examination really did test on pain. And that was a far higher number than that we anticipated seeing. So this is a breakdown of what I just said. 28% of the questions mention pain. 54% of the questions that mention pain actually tested for it, so about half. And this is essentially what we found. If you look at those domains that I mentioned, what is pain, how is pain recognized, how is pain relieved, or how is pain safely and effectively relieved, and how does context affect pain, what we found is 88.3%, or almost 90% of the questions focused on recognizing pain, which again is very consistent with what we prioritized back in the year 2000 around pain as the 5th vital sign. It simply got people to recognize pain, and the vast majority of the pain content on this exam was focused on pain recognition. We feel strongly that that supports a narrative about what happened. And this is just these are the basic competencies as well. And you can see that they're disproportionately in the area of pain recognition, that 2.1 is a specific competency almost 80% of the questions meeting that competency on pain recognition. So our belief is that when you look at the national crisis that we have of excessive opioid prescribing and unintended overdose death, you can see that on this slide, something happened with opioids around the year 2000. And the one thing we know that happened around the year 2000 was we made recognizing pain in America a requirement of every clinical visit, but we never taught our clinicians about what pain is, how to safely and effectively treat it, and how context affects it. We believe that the USMLE data supports this narrative that the education gap is in fact a perfect storm and a potential root cause of our crisis, where, again, addressing one domain without addressing the others causes a disproportionate effort without the support of knowledge, resources, and time that is necessary for addressing a very complicated problem like pain, and particularly chronic pain. So we view, and this is my last slide, we view the problem as now going back and re-educating, going back and changing curriculum so that we incorporate the education clinicians need about pain and addiction. The problem that we see is that we're so focused on opioids as the problem that it's hard to see that the lack of education led to this excess prescribing. And our hope is that we can get our accreditors and our test makers to publicly go forward and say that they expect curriculum to achieve competency in pain, or we will continue to fail the way we have over the many years that we've been working on this. So that is my goal and the goal of many of us, to get our accreditors of medical schools, nursing schools, pharmacy schools, acupuncture schools, naturopathic medical schools, psychology programs, etc., to make competency in pain a stated goal of their curricula, and then we can work towards how that can be attained in the most optimal way. And we want our test makers to incorporate more than just recognition in testing our students for that competency. The problem is that we have generations of clinicians who are on the front line of providing care and are already excessively prescribing because they don't know what else to do, or there's nothing else that they can do that's covered by insurance, or they don't have enough time, etc. We're working on programs to re-educate them and scaling it to the national scale that's necessary. We've started the country's first primary care pain fellowship, where primary care clinicians stay in their practice, but we leverage video conferencing and other technologies to work with them through a flipped classroom, academic detailing, coaching, and telementoring approach. Over a year, we just graduated our first class. We've almost doubled the second class, and our hope is that this will go statewide and then nationwide, where we'll have a trained educator in every primary care practice in America. Those of you who can talk to your legislators or lawmakers or regulators about this, we need their support, because if we can get this on the agenda, and I'm going to be speaking to folks in Washington on Monday about this in a national pain strategy program. If we can do it, we can probably get our primary care folks educated in 5 to 10 years globally. So with that, I thank you for listening to me, and I look forward to your comments and questions, and I'll turn it over to Dr. Gordon. Thank you.
Thanks, Scott. So as Scott said, the core competencies are really intended to be interdisciplinary, interprofessional, and I think he's given a great description of how we know that each discipline needs to address this and incorporate this. But one of the ways to advance this whole issue of pain education and quality of care is really through interprofessional education. This is the definition from the Center for Advancement of IPE. This is a UK organization that was founded in 1987. And it's not just putting students from different disciplines together in one room. It's really a situation when students from 2 or more professionals learn about, from, and with each other to improve collaboration and quality of care. So really for IPE to be present, all 3 of those elements must be part of it: about, from, and with. The other thing about IPE is that it requires active learner participation. It's a very different way than traditional didactic learning, and it's also case-based. So this is really a method of education that stresses a shared language, vision, and goals. There certainly is a huge case for IPE, a lot of rationale. I mean, I think every one of us recognizes the high demand for practice-ready teams in the healthcare environment. We know that high-functioning teams improves outcomes of care, and we know that the traditional model of uniprofessional silos often produces professionals that don't necessarily speak the same language, and sometimes even creates competition among disciplines. Back in 2010, the World Health Organization and other leaders in the globe really advanced that IPE should be part of all of our education and pre-licensure programs. So interprofessional education reinforces that socialization of trainees at all levels to patient-centered care and interdisciplinary pain care, which is certainly critical for pain management. And again, stresses our interdependence and really focuses on core competencies about our roles and understanding. There are core competencies for interprofessional collaborative care, and I just want to point those out because they very much complement the core domains that we see for pain. In this upper left-hand corner, you'll see interprofessional teamwork and team-based practice that really focuses on how teams plan, deliver, and evaluate care. In the upper right-hand corner, you'll see there's interprofessional communication practices, and that really stresses how we communicate amongst ourselves, with patients, with families, and communities, and really supports that team approach of communication. Down in the bottom right, you'll see roles and responsibilities for collaborative practice, really critical about understanding, having knowledge of one's own discipline in terms of role and scope and those of others in the team. And then really importantly, I think the left-hand corner, which is values and ethics for interprofessional practice. So this is really how do we create that climate of mutual respect and shared goals and values when we're caring for patients. So I just want to give you one example, like how do you put this together? How do you take the core pain competencies and the interprofessional model and try and integrate those into your system? So I can speak to my own local experience. Back in 2011, Scott kind of alluded to, the Institute of Medicine in the United States created a blueprint for transforming pain care in the United States. And they really said that we needed to change the way we educate and prepare health teams. So late in 2012, we took the Johns Hopkins list of doing an educational gap analysis. We surveyed all 6 of our pre-licensure health science programs here at the University of Washington to find out what were they doing with pain and content. And not surprisingly, it was lots of gaps. We found that the number of hours devoted to pain ranged anywhere from none in the social work program to 20, let's say, I think there was 8 in nursing, 28 in medicine. Dentistry actually had 117, and the physician assistance program had the most. They had 145, very focused on psychosocial, but big range of gaps. And you know, most were using traditional didactic teaching methods, and we found that comparing this to the International Association for the Study of Pain curriculum, we really had gaps in topics like ethics and some of the special topics. So part of the work that went on in the US through our national pain strategy was to create a program called Centers of Excellence in Pain Education. And the University of Washington was lucky enough to be one of those, to create case-based modules that are free and online. You can see in the bottom right-hand corner, there is a web site for this. We developed a module on a young gentleman who had acute pain from a necrotizing soft tissue infection with a heroin opioid use disorder. And you'll see that we did an active learning case-based session that you can, again, get on the website as well. And the first two objectives are some of the core objectives for the interprofessional core competencies. And then the third objective really focused on one of the core pain competency domains, that is, how is pain relieved? And that really focuses on that collaborative approach that teams need to do with decision-making and patient agency and diversity of treatment options in these situations, as well as health promotion. So it was a really nice way, I think, to blend that team approach with the pain competencies. This was part of both a learn and discovery exercise we used with the students, as well as an evaluation of the course. We had students use this validated interprofessional collaborative competency attainment scale to do a self-assessment at the beginning of the course and then at the end to see how they might improve their understanding of some of these core domains. We were pleasantly surprised. We had more than 160 students, I think, from all of our schools in 2 sessions. We found statistical improvement in all core of these domains, but the largest effect size was really with that patient-centered approach in the team functioning. So I think that bringing this together was an example of how you can move it forward. Obviously, there were struggles with having students come in with different levels of experience, but really the comments from the students were just how helpful this was to really get a greater understanding of other disciplines and how important pain is and incorporating that patient-centered approach. So I'm going to let Judy take over, and Judy's going to talk a little more about kind of a much larger program and evaluation of that.
Thanks, Deb. Despite the important work that Scott describes and that others are doing, and the results from collaborative pain research that Deb has described, surveys continue to report a lack of pain content in professional programs worldwide. And there seems to be still few opportunities for interprofessional learning so that we learn from each other. And as Scott mentioned, we were shocked when a previous survey showed that veterinary medicine graduates received more pain content than the rest of us. In Toronto, we have felt that introducing pain content at the pre-licensure undergraduate level is very important for students to have that foundational knowledge, and also to learn with whatever professional departments or faculties are available, whether it's 2 or more. Our 20-hour pain curriculum is mandatory. Students have to go from these faculties. And 50% of the time is spent in small interprofessional groups working on patient care plans. And we do take attendance. This is considered clinical. So the students learn about each other's roles, what they bring that's common, what is unique, and they learn to value collaboration. We receive many questions about our process. So we have formalized our experience in this pain interprofessional curriculum design model, or PICT model. It focuses on patient-centered approaches and collaboration versus the usual only uniprofessional ones. The model emphasizes the key steps from our experience from why making the case about culture and the need for pain content is important, deciding who in our community will help, what content to include, and how we would implement it. It is based on the IASP curricula and the related competencies domains that Scott has described. And it emphasizes integrating the patient voice, their priorities, and the context, which are so key, I think, to having successful management. In terms of uniprofessional pain content, this is a recent paper from John Lozer and Michael Shatman that documents the need for chronic pain management in medical education, which they describe as a disastrous omission. And their recommendations are that chronic pain management needs to be a part of the pre-licensure or undergraduate pain education, that pain questions need to be a part of the U.S. medical licensing exam, which Scott is working on, and that the students need multi-professional and multidisciplinary learning opportunities. And there are good resources for this. For example, this paper by Beth Mearson Hogan and colleagues has really excellent recommendations for including pain content in the medical curricula. There are also resources that are helpful in terms of integrating core competencies in curricula for nursing and also physiotherapy. So at the uniprofessional level, there are good resources to help people with integration. The use of e-learning pain resources is increasing, and certainly we have been looking at how we can do this with our own curricula. And we developed the pain education interprofessional resource where students follow a surgical patient through 3 modules. And you can see module 1 has a preoperative pain focus. Module 2 focuses on postoperative pain assessment. And module 3 is about persistent postoperative pain management for the patient whose pain transitioned from the acute to a persistent problem. The objectives for each module are mapped to the core competencies and the IASP domains, and the resource begins with a pre-test, concludes with a post-test, and there are knowledge translation exercises at the end of each module, and then they do an interprofessional KT plan at the end. We did not want these modules to be didactic slide presentations, and we wanted them to be very interactive, and the black buttons that you can see on each of the modules are the interactive elements. To do this, we used simulations, animations, commentaries to incorporate pain mechanisms and key assessment and management issues. We wanted the evaluation assessments to be embedded, so we used video vignettes of simulated authentic patient context that we scripted with standardized patients. And the students also have opportunities to evaluate clinician-patient interactions. The data capture, again, we wanted both formative and summative feedback. We wanted students to have feedback as they worked through these modules so that they have feedback about in real time to kind of guide their understanding. And there are many commentaries throughout that they can learn as they go. We were pleased that the results were positive, that the usability and design scores were high with a 4.3 out of 5 rating. And the pain knowledge and belief scores increased by 21%, and this is without facilitation. The resource can be used individually or with groups, and certainly facilitation would have helped them even to increase their knowledge. Advocacy, advancing pain curricula and pain competency requirements for licensure that Scott has talked about involves adequacy, and advocacy has been defined by Bully and Nwesser and Hogans in the IASP fact sheet number 8 as a process of influencing public opinion at all levels, from the general public to government ministers, with a view to improving knowledge about pain, its effects, and its treatments. And I think Scott has talked about this in terms of future directions of how we are going to change the culture around pain that we have. We did examine our competency, the competencies in our licensure documents for our health science faculties across Canada, and it was disappointing. Nursing had 6 competencies, dentistry had 2, but the others had none. And again, when we compared with veterinary colleges, they had 10 very specific competencies related to pain assessment and management. So our conclusion was that influencing professional bodies to increase entry to practice pain competencies for licensure may have the greatest impact on pain education and patient care. We are all working, I think, to be change agents. There are many suggestions on the fact sheets on the IASP website, but here are a few that we particularly feel are important. First, meet with university leadership to try and get support. And these can be deans, but they can also be course coordinators, chairs of curriculum committees. Using patients and their feedback is very important, and we do include patients on our panels. We have them as part of our seminars. There are good qualitative data that help to paint the picture of this problem, and student feedback about clinical competency, how they feel in the practice, are all important ways to use these data. If you have any previously developed model or resources that you can modify, that is a good place to start rather than starting to try and do it again. There are faculty development programs, if you can be a part of those and get pain in there, involving clinical colleagues in design and implementation. I mean, the colleagues that are first line who are working with people every day, whether it's in the community or the hospital settings, they can be very strong advocates for change in pain education. Integrating interprofessional education activities, both at the pre-licensure level as well as continuing education activities, I think are important, particularly the continuing education strategies that Scott mentioned some examples, because if people are graduating without a baseline education, pain education foundation, what are they basing current decisions on? And attending national meetings or state or provincial meetings is a way to network, to find colleagues who are also able to support, to hear about their strategies and the trends in pain education. So there are some good ways to try and yourself be an advocate in your particular context. There are many resources on the IASP website associated with the global year. They've been developed by interprofessional experts. representing the IASP chapters all over the world under the leadership of Paul Wilkinson. And we hope that you will use these, modify, use, adapt, whatever fits your particular context, but we're hoping that you will find them helpful. And I'm going to turn it back now to Deb.
Thanks, Judy and Scott. Yeah, that's really a lot of great information. I think we see that we have a lot of evidence of actions that need to be done, and I think there's a lot of great resources that we can harness and things we can do personally and locally as well as regionally. So I just want to remind everyone in the audience that if you have questions, just type them into that question and answer box on the Zoom screen. It looks like we've got about 8 questions in there already, so I'll just open this up for discussion with the panel members, starting at the top. This first question I think is a little challenging. Is how do we make treating pain rewarding for professionals? How can we do that? And then I can understand where I think sometimes people have felt a gap and a loss in terms of knowing what to do, and it can be very frustrating. So Scott or Judy, do you have some comments on that?
Well, this is Scott. I hope you can hear. I think, I go to why is pain not rewarding, pain management not rewarding. I can't think of a more rewarding thing to do than to relieve someone's pain, and it's why I went into the field, and I think it's why most clinicians go into healthcare, to help treat suffering and relieve suffering. I think that it's made unrewarding by the fact that we don't have the knowledge, the skills, the tools, the resources, or even the science that we need to do a better job. So it's frustrating when you have vague ailments that are hard to objectively understand, and then don't feel that you have appropriate responses to that. And particularly when, at least in North America, we're forced to actually grade the pain and then respond if the number is too high. So it makes for kind of a perfect storm and dissatisfaction. I think making it rewarding is going to need addressing the education gap, the resource gap, and the science gap that we experience in pain management. Thank you.
It's Judy. May I just add that I think it's hard sometimes to be a professional working on your own, and if you can find colleagues that you can consult. I mean, this is one of the benefits of the programs like the ECHO program or the program that Scott mentioned, so that again you're learning, you're sharing and learning from others about strategies that they have found to be helpful.
Great, yeah, I completely agree. That kind of actually leads to the second question. There's a question from Brazil. It says, there's no opioid crisis in Brazil. Do you know why?
I guess I'll start. This is Scott. I don't know why, but the things that I would wonder about is, if really the question isn't there an opioid crisis, which really is there an opioid problem? We had an opioid problem in the United States before we had an opioid crisis. So the problem is that we're excessively using them, and I would argue that we excessively use them for a lot of different reasons. And so is there an issue of excessive use of opioids? If there isn't, maybe Brazil uses opioids appropriately. What I find in countries that haven't had problems balancing opioid prescribing is that opioids are barred and they don't have access. And that's the worry that we have, which is opioids, are excessively prescribed in the US. We've got to pull back dramatically. I have always believed that if we use them responsibly, like many, many other very risky drugs that have a narrow therapeutic window, that we can use them safely. You know, we use drugs that can kill people safely all the time. So the problem isn't the drug; it's how we're using it and the care that we're bringing to bear. So I don't know what's happening there in Brazil, but I look at those factors. I hope that helps clarify the answer to the question. Anyone else?
I agree.
Yeah, I don't really have anything else to add. I think that people have overused opioids because they don't know how to manage pain otherwise. That's kind of, they got little information about, you know, multimodal and non-pharmacologic self-management strategies, and I think, you know,
nothing else is covered.
Right.
In the US, yeah. And that doesn't mean that opioids shouldn't be used in some situations, but, you know, much more rarely. Yeah.
So the next two questions I think I'll present together. There's two separate questions. One is about what's the best way to incorporate patients into this whole effort to improve interprofessional education, and the second one is really about what's the role of basic scientists? Can we, how do they fit in? How can they contribute? So I think I'll start out by talking about how I think we can incorporate patients, and I think it's absolutely critical. I think you can have patients share their narratives in classes. They can be part of groups that plan education. I think their voice is absolutely essential, and even in quality improvement teams, it's super important to engage patients and families who've been through that experience so that their voice can be part of that.
It's Judy. Sure. I totally, I think that's a really good way to do it. I mean, we include, we do have patient panels, but we also have patients as a part of the seminars. They get, and also I think with some of the planning, certainly in terms of any research that also involves education, they are a part of all of the processes. I think it helps the student to understand really the goal of what they're doing in terms of patient care, particularly pain care. And these can be the people who are basic scientists as well as clinicians, because, as someone said, the cell belongs to a person, and it helps to really focus what we're all about.
So in terms of basic scientists, Scott, do you have any thoughts? I mean, I remember going to, gosh, I think it was an IASP plenary session years ago, and there was a basic scientist who was saying kind of one of the most rich experiences he had was once a week he would put on a lab coat and round with the pain service, and how important it was to kind of understand their challenges and problems, and it helped to drive research questions. And I mean, it was really a nice interplay to have in the clinical world. You know, the researcher and the clinicians get together regularly.
Absolutely, Deb. You know, the issue is that if science is done in a vacuum, it winds up still being effective science, but it answers questions that aren't relevant. And you know, if we work in a vacuum, I think that's the outcome. And what, you know, the value of science and interprofessional conversations and learning together is that we see the questions from different perspectives than we can have from our own, because we're intrinsically all subjectively biased. We all are viewing a problem from only one perspective. And when you work in an interprofessional environment, you realize that it's just so enriching at all levels. So the same that you mentioned about the scientists coming in and working in the clinical space, which is, really an aha kind of moment. We started this center at the UC Davis called the Center for Advancing Pain Relief, and our goal is simply to bring down the barriers, to bring down the silos. So it's truly an uncenter. And we've held symposia where we've invited people who actually didn't even know they were doing pain research or doing pain studies or producing pain programs. And they're people from the engineering school and the social sciences and humanities, the law school, the veterinary school, the medical school. We've had engineers who are developing devices for migrant workers to have less back pain. Programs where we have artists talking about the impact on social isolation and pain, and things of that sort. So when you do this, you just feel this aha effect of just relieving that tension of the isolation, and you realize that you just get a broader view and a better view of what each of us is doing in our own disciplines or silos, and the walls start coming down. So I agree completely.
Great, thank you. Yeah, I think that kind of helps answer some of the questions. The next question was, how can professionals become better able to advocate for more education and for more support of pain research? And I think, Judy, you kind of answered some of this in one of your last slides about some of the personal actions people can take in terms of collaborating with others and going to stakeholder and leader groups and sharing information.
Right. I think it sometimes is difficult for professionals who try to work alone. And I think there's a network. Some of our universities, as Scott has mentioned, we also have a Center for the Study of Pain that is multidisciplinary, multi-professional. And we really need to learn from each other and also organize initiatives as a body. We have more respect when it's from a group, when we go to negotiate for a particular education initiative or for funding to support an educational research project. So try to network, and that's one of the really pluses of IASP and also the chapters in individual countries.
And could I add on that? This is Scott. That I view this historically as we've been trying to get advocacy for pain education in my career for 25 to 30 years, and I think it's important that we recognize that in many ways we've failed, and I think that failure can be very instructive in terms of what we need to do, at least in North America. I'd be very interested to hear from other continents and countries about whether this seems relevant to their experience. But I would argue that we put the accent on the wrong syllable, that we focus on the content and we're not looking at the process. The process is that all of our schools for health professionals, no matter what profession, have to be accredited. And those accrediting bodies drive what goes on in those schools. Or the graduates have to pass a test, and those tests drive what have to go on in those schools. So I think that for a brief time, we should recognize that curriculum is extremely important, and we actually have incredible examples for curriculum already out there and more to come, but that we won't get to use them unless we get those accreditors and testers on board. And my experience is that if we go to these schools and say, are you doing this? Just like the survey I showed you, they're going to say they're doing it. But when objective viewers look at their schools, they're not. There's no evidence of real curriculum. So we have to ask the accreditors to hold them to that standard. And once we do, I feel very confident that they will incorporate real training that leads to competency in in pain management, and that the debate will then shift to what is that training, what's the optimal training, and that will be a really interesting process of looking at different ways of training people to be good pain managers.
Scott, could I just add, it's Judy, just one more thing on that. In terms of the accreditation issue, there is a well-respected medical faculty in Canada who did not get their usual excellent accreditation because of feedback from students around pain, around several areas, but one of them was around a lack of sufficient pain to feel competent in practice. And I also would emphasize that we all have patients, and we all have their narratives and their stories. So again, going beyond some of what would be usual to think outside the box and include some other stakeholders, because I think they can have a very, very powerful voice to help us. Thanks.
Thank you. So here's a comment and a question. It says, it appears that all IASP efforts are directed to students and practitioners in North America. What about the rest of the world? Will efforts be made to bring excellence in pain education to less developed parts of the world? And what will be done to internalize or internationalize, I guess, the North American efforts? I'm going to let Scott maybe take that first because of the work done in Japan 2 years ago with IASP, with I think more than 14 or 20 countries that came together around the pain competencies. But I do want to just point out that IASP does have a unique grant program for improving pain education that is specifically targeted at developing countries. And if you go to the website, you can see there are grants up to $10,000 available to improve essential pain education. I think we just happen to have North American programs sprouting up that led to us being on this webinar, but this doesn't reflect in any way IASP focusing on North America.
I'm glad you said that, Deb. You know, the fact that the U.S. has been more of a mover in this area than in other countries is, I think, probably reflects different things, but it doesn't reflect the fact that this should only happen in North America or in the U.S. Or in Canada. The bottom line is, I think we're all struggling in our countries around this issue, and the U.S. I think is more advanced in, I think, recognizing the problem, and then it's a silver lining of a horrible epidemic, you know, of a horrible public health problem here that we're looking at what is the root cause, and I think this is starting to become clear because of some of the crises that we're experiencing. I hope that other countries don't have to experience these crises to look at what can happen if pain isn't well treated and clinicians aren't well educated and science isn't funded, etc. But I'm not sure what to say about other countries because we don't really know, and we started a process of seeding a group at the IASP World Congress in Japan 2 years ago from multiple countries to talk about, you know, what's happening about pain in our countries in terms of pain education. Are there goals? How can we work together to help each other? It was the beginning. It was an important meeting, and I hope organizations like IASP that have the footprint to allow different countries to talk to each other will continue to support that kind of programming. I think it's extremely important.
It's Judy. I think as a person from Canada, we are part of North America, but I think, you know, there are differences amongst all of our countries. I felt really quite pleased with for example, the fact sheets that were developed by people from not just North America, but from, you know, the terrific work that's going on in Britain, in Europe, in Australia. And I think one of the things I've noticed is that sometimes we use only the literature from, let's say, this side of the ocean or the other side of the ocean. And it may be that we need to be looking at, as much of the work right across the world, and including the IASP chapters, because some of it is very similar. It's surprisingly similar. Some of the issues are surprisingly similar. And there are strategies and colleagues who are having some of the same questions all around the world. And I think that is the role of IASP, which is so important to me, because I have colleagues everywhere, and I value their suggestions and their input. So I'm just, again, supporting that we look at the literature, look at the research. The IASP website has resources that are blends from a variety of viewpoints. And if you see something that is different, then, please communicate that, because we all need to learn from each other.
Yeah, well said. And I think the next comment actually helped address this. It's a comment coming from Argentina that said, I had no particular questions, but wanted to acknowledge the excellent presentations by all the speakers. Thank you very much for those kind words. Feeling that Argentina is still behind taking pain as a serious health concern, mainly due to cultural reasons. And this person sees the task of introducing changes as suggested in the webinar as a really big challenge. So I guess others have commented on, what is the resistance that people are finding and seeing when they're trying to improve education, and, how do you overcome some of those obstacles? I guess I could try and answer that a little. I think, people always say time and money are obstacles, but I really think that, these education is happening both at the pre-licensure undergraduate level and the graduate level. So it's happening. We just have to kind of connect the dots, I think, and get into the queue and participate in those. I think sometimes we wait for, I know I struggle personally with waiting for the curriculum dean or chairperson to make these changes. And sometimes it's just that advocacy that Judy spoke about is just, connecting with people and sharing some of this information, and things open up. That's what happened with our interprofessional education series. That structure was being developed, and we connected with those folks and said, hey, this is an important issue with opioid use disorder and acute pain management, and it was just a really nice fit. So sometimes the obstacles are not quite as big as we think they are.
May I just add that I think being realistic for what you have in your own context, this was the part of the model that around the process, it is trying to get stakeholders who are in your area to work with you and be helpful.
I'm looking at the clock. I think it's close to 15 after the hour, and I don't want to keep people over. I know we haven't gotten to all of the questions again. I think we'll take a look at those and see if we can maybe type in a response or two after. I think I'll turn it back over to Neil, because I think he has a couple of closing remarks, unless anybody, Scott or Judy, do you have any final thoughts?
No, thank you all.
Thank you for being a part of this today.
Great. Thanks, Deb. So as we wrap up here, I really want to thank Judy, Scott, and Deb for their really wonderful talks today. Thank you so much. I think this was a wonderful webinar. We also thank all of our attendees for listening to the webinar and for submitting your questions. I'd also like to thank Michelle Wood for all of her help in helping to organize the webinar. As you can see, there is more information that you can find out about the Global Year, and to view past webinars that we've had for the Global Year. You can just go to the IASP website, iasp-pain.org/global year, and you can see the hashtags to follow the conversation about the global year on Facebook. So one final note, we'll have a recording of the webinar available immediately on the IASP Facebook page, and we'll also have a recording available on the IASP website later today or early tomorrow. So if you'd like a replay, or if you have colleagues who might like to listen but weren't able to attend, you can access the recording. So with that said, we really hope you enjoyed the webinar today. Thanks again, everyone, to the speakers in the audience for attending, and we look forward to seeing you at the next Global Year webinar. So take care, everyone. Bye-bye.